Welcome. In this session, we're going to discuss assessment of the client who comes to you for foot and nail care. Now, I want to address just a couple of general issues first. One is the fact that there is going to be a difference between your intake assessment, which of course should be as comprehensive as possible, and follow-up assessment, which will focus on issues specific to that patient or client. The second is that, to some extent, the comprehensiveness of your assessment will be dependent in part on your care setting. For example, if you are working in a clinic and you're able to place the patient in a supine position, you would of course do an ankle brachial index measurement as part of your initial assessment. However, if you're working in a setting where clients come in to a large area and they're sitting the whole time and you cannot place them supine, you would not be able to do an ankle brachial index measurement. Instead, you would carry out the other aspects of a vascular assessment, and if the other components of your vascular assessment indicated a potential problem, you would refer that patient for further workup by a vascular surgeon. So those two general considerations, that you have your comprehensive baseline assessment and then you have your focused follow-up assessment, and that some modifications might need to be made based on your care setting. In this session, we are going to focus on the assessment parameters that should be included in your baseline assessment of a new client. So let's assume that this new client has come in to your foot and nail service. You have already consented them. They have read the consent, signed the consent. And now you are ready to get that baseline history and that baseline physical exam. That's where we're going next. So baseline history. You definitely want to know about their medical surgical history. You want to know in detail about conditions that would be most likely to affect either vascular function, sensory motor function, or the status of the skin and the nails. So in addition to asking them in general about any medical problems they have, about any past surgical history, you're going to ask specific questions about, has anyone ever told you you have bad circulation? Have you ever been diagnosed with peripheral arterial disease? Have you been diagnosed with diabetes? If so, type 1, type 2? How long have you had diabetes? How do you manage? Do you know your last A1C results? Do you check your blood sugars? And if so, what does your glucometer result average? You want to know about any conditions that would affect musculoskeletal and nervous system function. So certainly you're very alert to spinal cord injury, to any diagnosis of neuropathy. You want to be alert to indicators or to a diagnosis of arthritis, because that affects their ability to get down to their feet and to provide appropriate foot and nail care, all of those things. You want to ask them about any specific problems they're having at present. Many times it's a specific problem that actually brings them to your clinic, to your service to begin with. Maybe they're having a lot of pain with walking because of a plantar's wart or a plantar surface callus or a corn between the toes. You're going to ask about any problems with walking, and of course you'll observe that when you get to the physical exam. You want to ask about and observe for any lesions or wounds or ulcers or dermatologic conditions. Many times you'll observe kind of a dermatitis on the lower extremities, and you want to ask them, you know, it looks like you have a little bit of a rash here, it looks like you have some scaling here. How long have you had this problem? Are you seeing anyone for this problem? How is it being managed? You want to know how they care for their feet at baseline. Do they shower? Do they tub bathe? Are they able to dry between their toes? Do they have assistance with hygienic care and foot care? Who's trimming their nails? How does that happen? How is that getting done at baseline? And very important to get a medication list. many times this alerts you to a potential problem. Maybe in giving you my history, I failed to mention to you that I've been diagnosed with atrial fibrillation. But if you ask me about my medications, I tell you, oh yes, I'm on Coumadin, or I'm on aspirin, or I'm on Plavix, or whatever. So very, very helpful to get that medication list. You don't want to find out after the fact that someone's on anticoagulants. Okay, so you've gotten your history, and it's very helpful. I'll just mention this, very helpful to have a structured form to gather all of this data. You should have gotten a structured assessment form in your hard copy packet. So moving on to physical assessment, many times you're going to walk the client from a waiting area to the workstation, and of course as you walk with them, you're going to notice their gait. How steady is their gait? What's their ambulatory stability, their walking balance? Do they use any kind of ambulatory aids? Do they have a cane? Do they have a walker? Do they, have anything that assists them to get from point A to point B? The major components of your physical assessment will be vascular assessment, sensory motor assessment, skin assessment, and nail assessment. Those are the 4 areas that we're going to talk about right now. We're going to begin with vascular assessment. It's going to go right back to some of the things we talked about when we talked about normal anatomy and physiology and pathologic conditions affecting both the skin and the nails of the lower extremity. So of course, as you know and as we mentioned, healthy skin, healthy nails, normal hair growth, all dependent in part on normal perfusion. So a very good first assessment is to look at the skin, the hair, and the nails for any evidence of chronic ischemia. You all know that thin, shiny skin that you see in patients with peripheral arterial disease. So I'm looking first at the skin. I'm looking secondly at patterns of hair growth. If I have a patient with hairy toes, it might not be sexy, but it's a very good sign because it tells me that they're getting enough blood flow to their tissues to support hair growth. If I observe very sparse hair or no hair, I'm just going to check with the patient. Is this new? I don't see any hair on your legs. Is this the way it's always been for you? You've just never grown much hair? Or is this a change? Or for a woman, I'll say, do you shave your legs? I don't see any hair on your legs. Is that because you shave your legs? I want to know, do they grow hair? Do they not grow hair? If they're not growing hair, is this new or is this long-standing? What about nails? You know that a patient with peripheral arterial disease is not going to grow a nail of normal thickness. They can't. So they're going to have very thin nails, and frequently they'll have longitudinal ridges running from the base to the top. However, you also know that many of your clients are going to have fungal infections of the nails, and fungal infections tend to cause the nail to become thick and brittle. Fungal changes will obscure ischemic indicators. So if I have a fungal infection of the nail, I can't tell if there's any underlying arterial disease. I just take that off my list. I focus on what does the skin look like, what are the patterns of hair growth. The next thing I observe for is color. Many times you'll start with the client in a neutral position, and you look to see, is the color of the skin on the right leg the same as on the left? Is the color of the skin on the legs the same as the color of the skin on the arms? Or do you note pallor or cyanosis, a gray tone? However, even the patient with fairly advanced peripheral arterial disease will typically have normal appearing color in a neutral position. So the next thing you're going to do, assuming that you have the client in a supine position, is you're going to raise the leg and you're going to observe for color change. When you raise the leg, do you see pallor? Do you see cyanosis? Do you see a gray tone? Then you're going to put the leg down. So you're going to sit your client up and put the leg down. And you're observing for dependent rubor. So you look at color in the neutral position, what happens when you elevate, what happens when you put the leg down. The person who has normal perfusion, there will be no change in color. The patient with significant peripheral arterial disease, you will see elevational pallor and dependent rubor. The next test is a test for venous filling time, and it's actually very helpful to do this at the same time that you're checking for color changes with elevation, color changes with dependency. To do venous filling time, you take the leg, you raise the leg and hold it up until all of the veins collapse. And once the veins have collapsed, you sit the client up, you put the leg dependent, and you count the number of seconds it takes for those veins to refill. Normally, venous filling occurs in less than 20 seconds. If venous filling is prolonged past that 20-second point, that's a strong indicator of significant peripheral arterial disease. So venous filling time, a very helpful indicator, gives you objective data. Having said that, what if you cannot see the veins when the patient's in a dependent position or in a neutral position? If the veins are very deep to the skin and you can't see them, you will not be able to do venous filling time. If you can see the veins, a very helpful test. What about capillary refill? Well, you know how to do that. We've been doing that for as long as we've been in nursing. Many times we will compress the nail bed itself. However, when you're doing capillary refill for a patient with foot and nail issues, usually it's better to compress the toe pad and count the number of seconds till the color returns. And this is why. Go back to the fact that many of our patients have fungal infections and you will not be able to detect blanching and refill going through that thick fungal nail. And some of your women will have nail polish. So better to do capillary refill using the toe pad, not the nail bed. Finally, you can check for temperature. We do not spend a lot of time on this because, as you very well know, a lot of people with normal perfusion have cold feet. But it only takes seconds. So you can take the back of your hand, you can start at the knee and you can come down, and you're really checking more for a change in temperature than absolute temperature. So if I'm coming down the leg and the leg's warm, and then I get to just above the ankle and there's a definite change, and I go from warm to cool or warm to cold, very significant. So we start with just general observations. We look at the status of the skin. Is it thin and shiny, or does it look pretty normal? What about patterns of hair growth? If hair growth is sparse or absent, I ask about changes. Is this a change? What about the condition of the nail? If there is no fungal infection, I'm looking for thin, ridged nails. If there's a fungal infection, I skip that part. Then I'm going to look at color. I'm going to see what happens with elevation. I'm going to see what happens with dependency. Elevational pallor, dependent rubor, a very significant finding. You just don't get that unless you have significant peripheral arterial disease. If the veins are visible, I'm going to do the venous filling time test, elevate the limb until the veins have collapsed, put the limb dependent and count the number of seconds for the veins to refill. Cap refill, using the toe pad and expecting cap refill to be 3 seconds or less, and finally temperature. Then I come to the very objective measures of vascular status, and the two critical objective measures are pulses and ankle brachial index measurement. We've already talked about the two pulses that should be palpable in each lower extremity. The dorsalis pedis, which, as you remember, runs between the first and second toe over the arch of the foot. So I'm going to start at the groove between the first and second toe, and I'm going to come down over the arch of the foot, palpating for the dorsalis pedis. The posterior tibialis, you remember, runs on the medial aspect of the leg, the inside of the leg, behind the ankle bone. So I put my fingers in that little groove and I palpate up until I find that pulse. And then I'm going to document. Are the pulses normal? Are they diminished? Are they absent? If I cannot palpate, I will get my Doppler to see, can I hear the pulse with the Doppler? Then we're going to do an ankle brachial index if we're in a setting in which that is feasible. So the key elements of getting an accurate ankle brachial index are to have the patient supine and quiet for about 10 to 15 minutes before the test is done. And then, as you can see, you're going to get your blood pressure, systolic blood pressure at 4 points. So you're going to get the systolic blood pressure in the right brachial artery, left brachial artery. You're going to then get your systolic blood pressure on the right dorsalis, right posterior, left dorsalis, left posterior. So to get right and left ABI, you take 6 measurements. Right brachial, left brachial. On the right foot, the pressure over the DP, the pressure over the PT. Same thing on the left foot. Very important point, you get all readings, all pressure readings are done with the Doppler. So you never use the standard stethoscope, you use the Doppler stethoscope to get your brachial pressure readings and to get your pedal pressure readings. Then the calculation. Of course, you can use your calculator, and this is how you do it, and you want to make sure you get this right because otherwise your ABI will be wrong and you'll have inaccurate data. So here are the things you have to know. You use the highest of the 2 brachial pressures to calculate both the right ABI and the left ABI. So let's say that my right brachial is 120 and my left brachial is 110. Strike through the 110. You're not going to use that at all in your calculations. 120 becomes the denominator for both the right ABI and the left ABI. So I'm actually going to put it on the board. Right and left. Now let's say that on the right leg that your DP is 124 and your PT is 118. You throw away the 118 and you use the 124. So you take the highest of the 2 pedal pressure measurements on the right, and that becomes your your numerator. And the highest of the 2 brachial pressures becomes the denominator. Let's say on the left that the DP is 120 and the PT is 110. Then you have 120 over 120. So I'm going to do this one because it's easy, 1.00. But to calculate the right, how would you do it? You would take out your calculator. You always enter the ankle pressure first. So you would turn your calculator on, and you would enter 124 divided by 120 equals, and that gives you your ABI. It's the comparison. Pressure in the arm, pressure in the leg should be about 1. What if I had a reading where the pressure in my leg was 60 and the pressure in my arm was 120? That would give me a 0.5. I already know that there's a significant problem with perfusion to that leg. So let's look at interpretation. We've already said they should be pretty much the same. So 0.9 to 1.3 is considered normal. That's the normal range. If you're somewhere between 0.5 and 0.9, you definitely have peripheral arterial disease. There is interference to blood flow to that limb. If you're somewhere around, say, 0.7 to 0.9, that's moderately severe peripheral arterial disease. If you're 0.5 to 0.7, that's progressively more significant. So as you come down from 1, it tells you that there's progressive interference to blood flow. So 0.5 to 0.9, mild to moderate peripheral arterial disease. The lower the number, the more serious the interference with normal blood flow. What if it's higher than 1.3? It indicates that the vessels are probably calcified, that your ABI reading is not valid, and that they need to be referred to vascular for further workup. What if your ABI is less than 0.5? It means you have severe peripheral arterial disease, and that patient needs to be referred to vascular. So ABI is basically a screening test. It tells you they're in normal range, or they have evidence of mild to moderate disease. We need to watch them, and they probably need to be worked up. If it's less than 0.5 or greater than 1.3, they need an urgent referral. Then the last thing on checking for vascular status is check for edema. And of course, you know how to check for edema, so you put pressure in the soft tissue right around the ankle or in the pretibial area, and you're looking for pitting. And then you're looking to see, well, how far does that pit go down and how long does it take to resolve? And here's your scale. If it's 1 plus edema, it means that you've got a 2 millimeter depression. And it typically resolves in less than 10 seconds. But 2 millimeter depression is pretty significant. So 1 plus 2 millimeter depression, 2 plus 4 millimeter depression. So you always take the number and double it to see how many millimeters of depression you have. So a 4 millimeter depression is 2 plus edema. It's usually going to take at least 10 to 15 seconds to resolve. 3 plus edema is 6 millimeters, and it takes a couple of minutes to resolve, 1 to 2. And 4 plus, I don't know if I've ever seen 4 plus, is 8 millimeter depression, 0.8 centimeters. So 8 millimeter depression and takes more than 5 minutes. Very, very, very severe edema. So vascular assessment. You start with your general screens. Look at the skin, look at the hair, look at the nails. Check the temperature. Then you do your very specific testing. Check your pulses and check your ankle brachial index. If you're in a setting where that's feasible, check for edema. Okay, now we're moving ahead to sensory motor assessment. We're going to start with sensory function. I'm going to actually grab a couple of things and show you. So the tool we use to do sensory motor testing is known as the Sims-Weinstein monofilament. And this is a validated and very simple test that gives you very accurate data. So look what it tells you here. You're going to press this against the foot at 10 different sites. And I think this shows you pretty clearly. First, third, fifth toe pads, first, third, fifth med heads, below the arch, medial and lateral, over the heel, and then on the dorsum of the foot, somewhere between the first and second toe. In doing the monofilament testing, you should press it against the foot with enough pressure to turn it into a C. That's exactly what you see on the top. Now here's how we do the test. We first show the patient on their hand so they know what it feels like. So we press it against their hand, and then they'll usually say, oh, I feel that, but it doesn't hurt. Right, it feels like a little fishing line. Now I want you to close your eyes. I want you to tell me when I touch the bottom of your foot, and if you know where I touched you, I want you to tell me where. I want you to notice two things you don't do. You do not do back and forth, back and forth. My eyes are closed. You put steady pressure, turn it into a C, remove it. Give me a minute, give me a second to respond. So you touch, press, remove. I should say, I feel it over my big toe. Okay? Touch, press, remove. I feel it over my third toe. If the patient fails to respond in 3 seconds, you move to the next testing site and you can come back to that at the end of the test. So don't do back and forth, do steady pressure and then remove it. And do not prompt me. Don't say, did you feel that? Did you feel that? Did you feel that? Because of course I'll say, yes, yes, yes. So instead, you just say, tell me when you feel me touch your foot. Finally, do not touch the foot anywhere else. So, you know, it took me forever to learn not to hold their foot with my hand, because if I'm holding their foot with my hand, they might be responding to the pressure of my hand. Instead, I want their foot on the examining table when I do this test. Now, most sources recommend this 9 or 10-point testing sites. You'll see some modified monofilament testing where they might test only 3 or 4 sites. But in general, we test all 10 sites unless there's a reason not to do so. Now, let's say a patient does not respond to the 5.07. I've looked again at that area to be sure there's no callus that would explain their lack of response, no callus. I've tested them twice, they did not respond. What does that mean? There's 2 approaches. I will tell you that bottom line, it means that they have loss of protective sensation in that area. And we're going to come back to what loss of protective sensation means from a clinical perspective. In centers where they test all 10 sites, patients are considered to have across the board loss of protective sensation if there are 4 or more sites where they do not respond. Other clinicians will say if there's any site where they do not respond, I'm concerned. When you're taking the certification exam, if they ask you which of the following would indicate loss of protective sensation in the right foot, and they say patient responds to 8 out of 10. No, that wouldn't meet the criteria. Patient responds to 7 out of 10. No. Patient responds to 10 out of 10. No. Patient responds to 5 out of 10. Yes. If they fail to recognize touch at 4 or more sites, that foot is considered to have loss of protective sensation. In many areas, the way you document response to the monofilaments is you'll have a drawing of the foot on your assessment form, and every point where they recognized the monofilament, you put a plus, and every site where there was no response, you put a minus, so that you can clearly see. They responded at 5 sites, they failed to respond at 5 sites. Anytime there's failure to respond at 1 or more sites, you're going to flag that patient's records. You know that that patient has some degree of sensory neuropathy, and you're going to want to follow them with testing at least every 3 months. Now let's talk about what loss of protective sensation means. What that means is that you are not going to know if you have a little pebble in your shoe. You're not going to know if your shoes are too tight. You're not going to know if the tops of your toes are rubbing against the tops of your shoes, because you have lost that protective sensation that normally helps us protect our feet. You or me. If I'm walking down the street and I get a little pebble in my shoe and my arms are full, of course I don't want to stop. So first, what will I do? I'll try to modify my gait so I'm not walking on the pebble. But if that doesn't work, what do I end up doing? I stop, I put everything down, I take off my shoe, shake out the pebble, put it back on. But what if I had loss of protective sensation? I wouldn't know to do that. And I would end up with tissue damage. Same thing when we buy cute shoes that don't fit. Our feet tell us. And that causes us to, number one, alter our level of activity. We stop walking so much. We stand still, we sit down. We take off the shoe as soon as we can. And we don't wear that shoe the next day. But what if I didn't feel anything? What if I didn't realize that my shoes were too tight or they were rubbing? I would just keep wearing them and I would sustain tissue trauma. That's why it's called loss of protective sensation. You've got enough nerve damage that you can no longer protect your feet effectively. That's what the 5.07. 5.07 is also known as a 10-gram monofilament. There's another monofilament known as the 6.10. This is a 100-gram monofilament. It's 10 times as stiff as the 5.07. It takes a lot of force to make it turn into a C, and it's borderline painful. You do not have to test with this. The gold standard is 5.07. If you also have access to 6.10 monofilaments, it's very helpful, because if I have a patient who fails to respond to 5.07, I will test them with 6.10. Here's what they will tell me. I'll say, now I'm going to do another test. Let me show you this. I press it against their hand and they will say, woo, that's really stiff. That kind of hurts. I'm like, okay, I'm going to test this on the bottom of your foot. They'll be like, I know I'll feel this. But what if they don't? It really catches their attention if they fail to respond to this. If I tell them there were 5 areas on your foot where I touched this and made it bend, and then I came back and did it again and you never felt it. Makes them much more aware of their progressive neuropathy. If they fail to respond to 6.10, they're considered to be insensate. So that's what we were just talking about. No response to 5.07. If you have access to a 6.10, you can do follow-up testing with the 6.10 that helps you to determine whether they have any sensory function left. No response to 5.07, loss of protective sensation. What does that mean to me in counseling this patient? It means you should not be buying your shoes off the rack, because you will not know if they're too tight or too short or rubby. Your shoes have to be professionally fit. What does it mean if you fail to respond to 6.10? It means you're extremely high risk for limb loss. I'm going to really ramp up my teaching even further. Never, ever, ever step in the shower without testing water temperature with your hand. Never, ever, ever go barefoot. That's true for 5.07 too. But you can see how you're going to ramp up your teaching as sensory loss progresses. 5.07, now I'm emphasizing we've got to get you in to have your shoes professionally fit. You cannot wear sandals with anything between the toes, so you can't wear flip-flops because your feet won't be protected and you can rub between the toes and not know it. You've got to shake your shoes out, never go barefoot, check your feet every night. 6.10, Ramp it up even further. Okay? Make them know they're extremely high risk. Extremely high risk. The other test that is frequently done is testing with a tuning fork for vibratory sense. Now, the significance of vibratory sense is that if all of your nerve pathways are working normally, if I strike a tuning fork and hold it against the bone in your foot, you will feel that vibration. On a day-to-day basis, vibratory sense doesn't protect you, but here's the significance. Almost all patients lose vibratory sense before they lose sensory function. So what it tells us is that that patient's headed down that neuropathic pathway. And that it's critical for us to do everything we can to enhance glycemic control to try to prevent further progression of the neuropathy. In the literature, loss of vibratory sense is heavily correlated with eventual ulcer formation and limb loss unless preventive measures are implemented. Here's how you test for vibratory sense. So you need your tuning fork. A lot of you have used a tuning fork, but I'm going to go over it for those of you who may not have. The critical thing is you hold it by the stem. You do not hold it by the tongs, the tines, because that stops the vibration. So you're going to hold it by the tip. You're going to smack it against your hand. Now let me point out one thing. If you hit it, nothing happens. So you never do that. Instead, you strike the tuning fork against the palm of your hand until you can see it vibrate and feel it vibrate. Hold, strike. Then you can put it on the patients on any bony prominence and ask the patient what they feel, and they should say vibration. You ask them to keep their eyes closed. Sorry, I forgot to tell you that they should have their eyes closed. So let's go through that again. I tell the patient, close your eyes. I'm going to do a little test with this fork. Okay, I'm putting this fork against your bone. What do you feel? I feel it vibrate. Then you're going to stop it, and you're going to say, tell me if it changes. And if I have intact vibratory sense, I'll say it's stopped. What if I have lost vibratory sense, but I retain pressure awareness? Then this is what will happen. So you take the tuning fork, you have me close my eyes, you tell me what you feel. I feel it. I'm not sure what I feel, but I feel it. Okay, tell me if it changes. You pinch the tines together. I don't say anything because I didn't feel the vibration to begin with. I only felt the pressure. Wait 2 seconds, move it. Then I say, oh, it stopped. I was feeling pressure. So normal, I feel vibration, it stopped. Abnormal, I feel it, no response. You move it, I say it stopped. That means I retain pressure awareness, but I've lost vibratory sense. So you see the tuning fork. There's a couple of different places where you can test. A lot of people test on the medial aspect of the first metatarsal phalangeal joint, kind of the bunion bone. That's a great place to test. Most of my patients tell me they feel it best there. You can also test just below the great nail. There's a big bone here. Some people will test over the nail itself, but remember a lot of our patients have fungal infections. That's not going to be very effective. So most of the time what you'll do is you will strike the tuning fork and you might hold it here or here. Ask the patient what they feel. Pinch the two sides together. Ask them to tell you if anything changes. And again, the significance. Loss of vibratory sense typically precedes loss of sensory function. It means that it's really critical to maintain tight glucose control to try to prevent any further progression. Then we want to do position sense testing. Now I want to back up and just explain why proprioception is so important. Now I want you to think of times when you've been going down the steps or walking over very rough terrain, and maybe you had your arms full and you really couldn't see your feet, but you were feeling your way down the steps or feeling your way over the rough terrain. And have you ever gotten your heel right on the edge of the step, but immediately you get feedback to the brain that your heel is on the edge of the step? That alerts you to lean back, grab the side rail. That's normal proprioception or position sense. It means that at all times you know where your feet are in relation to space, in relation to surrounding surfaces. Patients lose that. And when they lose that proprioception, it makes them very high risk for falls. What if you didn't know that your heel was on the edge of the step? Then you'd be very high risk to fall down the steps. And there's a very simple test you can do to evaluate proprioception. So you tell the patient, close your eyes. I'm going to move your great toe back and forth. I might push it up towards you. I might push it toward the floor. I might push it to your right. I might push it to your left. I want you to tell me which way I'm pushing your great toe. The patient with intact proprioception can tell you what direction their toe is being pushed. But the patient who has lost position sense cannot. And of course, they have to have their eyes closed. Okay, so that's sensory function. What's the most important? 5.07 monofilament testing. Okay? Eyes closed. Check at 10 points. Steady pressure till it turns to a C. If they do not respond to 5.07 and you have access to a 6.10, check with that. So you do monofilament testing. That tells you if there's any loss of sensory function. If you have access to a tuning fork, do vibratory sense testing. That's an early warning sign that neuropathic changes are occurring. And always do position sense testing, because if that patient fails position sense testing, you need to counsel them to always hang on when they go down the steps and to watch their feet when they're walking over rough terrain. The next thing we want to evaluate for is any evidence of motor neuropathy. And you remember from our previous discussion that it's the motor nerves that maintain normal muscle function. Muscle function in turn maintains the normal contours of the foot and normal weight bearing. So the things you want to do is you want to inspect the foot for any deformities. Do you have hammer toes, those contractures, the proximal interphalangeal joints? Do you have overlapping toes? You can see how all of these place the patient at greater risk for injury. Do you have a hallux deformity? Most commonly where the toe deviates away from midline and you get a bunion. So you're always looking for any of those things. You can also get abnormal prominence of the fifth metatarsal phalangeal head MTP joint, so that the fifth toe deviates from midline and you get a bunion neck. So look for deformities. You've already watched me walk. If you have access to the Harris mat, you can actually have the patient stand on the Harris mat and see how their weight is distributed. The other thing that's very helpful, and we'll come back to that, is that while the patient's standing, you can literally do a tracing around their foot, and you can use that to evaluate the appropriateness of their footwear. But the most critical thing in evaluating for motor function, first of all, inspect for deformities. Don't forget Charcot's foot. Now remember that Charcot's deformity tends to occur with repetitive fractures of the foot that causes total loss of the arch. So you end up with what they call a rocker bottom foot, Here you can see that rocker bottom foot, and you end up with very high pressures right over what should be the arch, and they very frequently develop ulcers in the mid-foot plantar area. So looking at deformities, not only are you looking for overlapping toes, hammer toes, claw toes, bunions, bunionettes, you're also looking for Charcot deformity. Evaluating muscle strength is helpful. So the critical things, you can evaluate their ability to dorsiflex against resistance and plantar flex against resistance. So plantar flexion, of course, is pushing the foot down, pushing the toes down toward the floor. And I can put my hand against the bottom of their foot and ask them to push against my hand and push down. Or I can put my hand on top of their foot and ask them to push up toward the knee against my foot. So it gives me a sense of their muscle strength. I can, of course, ask them to, twist their foot around to evaluate their range of motion. And inversion, eversion, sometimes they ask these things on the exam. As you can see here, inversion means that this is the foot that you've turned the great toe up, so you're pulling that up, and the fifth toe goes down. Eversion means the opposite. Big toe down, little toe up. So inversion, eversion. Just go over those terms because you have to know those many times. Okay, so you've done your monofilament testing, you might have done your tuning fork, you've done position sense. You've looked carefully at the feet to see are there any kind of deformities, bony deformities. Do you have overlapping toes? Do you have a bunion or a bunionette? Do you have Charcot's deformity? Do you have callus formation on the bottom of the foot, which speaks to abnormal weight bearing? All of those are significant. Now we're going to look at skin status and nail status. Now we're starting to get down to the specific elements that link to the care we will provide. So of course we're looking at the skin to see, is it dry and cracked? Do you have normal hydration? Is the skin wet between the toes, wet on the bottom of the foot from hyperhidrosis? I'm very alert to the presence of corns or calluses. Corns and calluses tell me that I have constant friction in that area. So if I have callus formation over the first metatarsal head, I clearly have abnormal weight bearing, and every time I step, I exert friction and shear right in that area. If I have corns, it tells me my toes are rubbing against the shoe or against each other. So I look for bony deformities, I look for corns, I look for calluses. I want to check the fat pads on the bottom of my feet to see, do I have a nice thick fat pad over the heel, because the heel gets a lot of force. If I've got thinning of the fat pad over the heel, that makes that heel very vulnerable to breakdown. And I have to be sure that the patient has padded footwear or has insoles. I palpate the fat pads over the metatarsal heads as well. And then I'm looking for any kind of lesions, ulcers, evidence of tinea pedis. So typically when we're doing our evaluation, we're doing our vascular assessment. Of course, we're noticing all of these things, but we focus on our vascular assessment, okay? Skin, hair, nails, temperature, pulses, ankle brachial index if I'm in a position to do that. I do my monofilament testing, my vibratory sense if I have a tuning fork, check position sense. Now I'm looking at the feet, and so I'm looking at skin status in general. I'm looking at the top of the foot to see are there any corns. I'm looking at the bottom of the foot to see if there's any calluses and to check fat pads. And now I'm looking actively for lesions or infections. So do I see evidence of tinea pedis on the bottom of the foot? What about the interdigital spaces? Do I see cracks? Do I see fissure formation between the toes? Do I see any lesions on the top of the foot? And And finally, I look very critically at the nails. Of course, I've been noticing the nails, but now I'm focusing on the nails. So how long are they? How much of that nail needs to come off? So when I look at this nail and these nails, I can hardly wait to get out my nippers and, my rotary drill to thin it down and clip it off. So how long are the nails? What are the contours of the nails? Do they curve down over the toe? Are they C-shaped and digging into the surrounding tissue? What's the thickness of the nail? Because if the nail's abnormally thick, I have to find a way to thin it before I can nip it, and we'll come back to that. Also, I'm looking at the color and the integrity, because we've already talked about the fact that fungal infections typically cause yellow, brown, black discoloration. It causes the nail to become brittle or crumbly. I'm noticing hygiene. One of the things I notice is there a lot of debris between the toes? Is there a lot of debris under the nail? That suggests to me that that person is not able to get between their toes and dry well, not able to cleanse the distal end of their toes well. So I'm going to go back and ask them again, tell me how you wash your feet, dry your feet. Paying attention to the cuticle, making sure that there are not breaks or tears in the cuticle that place them at risk for infection. Looking for evidence of fungal infection, as we've discussed, and looking for evidence of an ingrown nail. All of this we'll come back to. And then I need to assess this client's footwear. So remember when we talked about the value of doing foot tracing, so having them stand on a blank piece of paper, literally tracing around their foot. Excuse me. Then if I put their shoe on top of the tracing, and their shoe is much smaller than the tracing, what does that tell me? It tells me their foot's compressed. And I can show them, look how much smaller your shoe is than your foot. So that foot tracing, very, very helpful. For patients who have hammer toes, for patients who have overlapping toes, claw toes, patients who have corns, critical for me to look very carefully at the depth of the toe box. And the toe box is, of course, the distal end of the shoe where the toes sit. And if my toes are doing this, I need more depth in the toe box. If they're doing this, I need more depth. If they're rubbing, I need more depth. So if I have a patient with hammer toes and corns over the tops of the toes, and then I look at the shoe and I have a very narrow toe box, I know I need to refer that patient to have their shoes professionally fitted. I want to look at wear patterns to see if there's any excessive wear patterns, the condition of the insoles, and if you've been doing this for any time, I know you've seen some insoles in the inside of some shoes that were pretty horrific, where you needed to say to them, these shoes are worn out. They're not protecting your feet anymore. They're actually harming your feet. Critical for you to go get some more shoes. Do you have someone who can take you to get more shoes? Sometimes they don't know. They can't get down there. They can't see. They don't really know about the condition of their footwear. So many times we're educating them. What's the material of their footwear? For a diabetic patient, especially a diabetic patient with any foot deformities, really important that they either have leather uppers or soft fabric uppers that have some give. So pay attention to the footwear in terms of material, and then pay attention to, are they wearing socks? Are they clean? Do they have holes? Do you want to throw them away immediately? If so, hopefully you brought them some new ones. So pay attention. All of these things make a difference, as you know. And finally, as we've mentioned, you want to know about their usual foot care routines. How often do you shower or tub bathe? How do you dry between your toes? Do you use any kind of lotion or cream to your feet? What about between your toes? Don't glue them in. Don't say you don't put it between your toes, do you? Just say, do you put any lotions or creams or anything on your feet? You put that between your toes so that you can correct anything that they're doing incorrectly. Who takes care of your nails? Who's trimming your nails? Well, I am, but it's really hard because I can hardly see down there. It's like, okay, please don't do that anymore. Please come to see me and let me do it. Are you being followed by a podiatrist? All of this is very important information. So in summary, you should be able to do a pretty comprehensive assessment in a pretty short period of time. So you want to ask those critical questions on history, ask about any medical conditions, past surgical history, ask about medications, okay? Then focus your assessment on vascular status, sensory motor status, skin status, nail status. Then look at their footwear and their care routines, and then you are ready to take care of them. And that's what the next session will address. Thank you very much.